Assalamu alaikum. I am Dr. Mahmudul Hoque Jassy. I am from Dhaka Medical College of Bangladesh. Today we will discuss about calcium channel blocker. Calcium channel blocker basically is can be classified into three groups. One, there is dihydropyridine group, and second there is benzothiazepine, and third there is phenylalkylamine. Today we will discuss only about the dihydropyridine group. Today we will not discuss about the benzothiazepine group or phenylalkylamine group. In the dihydropyridine group we have amlodipine and nifedipine and nimodipine, and on the phenylalkylamine we have verapamil, and on the benzothiazepine group we have diltiazem. So today we will just restrict our discussion into amlodipine, nifedipine and nimodipine. We will not discuss about diltiazem and verapamil. We will discuss about diltiazem and verapamil in our later lecture. So let's start. So today we will discuss about the calcium channel blocker. Calcium channel blocker can be classified into three groups. Number one group is dihydropyridine, second group is benzothiazepine, and third group is phenylalkylamine. On the dihydropyridine group we have amlodipine, we have nifedipine, we have nimodipine, we have phelodipine, we have clinidipine, we have larcanidipine, we have istradipine, and we have nicardipine. On the benzothiazepine group we have diltiazem, and on the phenylalkylamine group we have verapamil. Today we will discuss only about dihydropyridine group. So on the dihydropyridine group, important calcium channel blocker are amlodipine, nifedipine, nimodipine, clinidipine, and larcanidipine. We use these calcium channel blockers a lot in the hospital emergency and in our chamber practice. So what are the indication of dihydropyridine? Number one indication is hypertension. This is the most popular and most famous indication. The following calcium channel blockers are used in hypertension. First, amlodipine, second, nifedipine sustained release preparation, third, larcanidipine, and fourth, clinidipine. Second important indication of dihydropyridine calcium channel blocker is Raynaud's phenomenon. We will discuss this condition in details in later part of our lecture. Third important indication is variant angina. Variant angina is also called prenatal angina, and it is also known as vasospastic angina. Number fourth indication is preterm labor. Fifth indication is subarachnoid hemorrhage. Of the dihydropyridine group calcium channel blocker, only nimodipine is used in subarachnoid hemorrhage. Sixth indication is intracerebral hemorrhage with ventricular extension. Only nimodipine is used in this case. We will discuss in details in later part of our lecture one by one of these indications. Now our first indication is hypertension. That means how does amlodipine, nifedipine, or larcanidipine or clinidipine lower blood pressure? So this is a cardiovascular system. Cardiovascular system has many components. This is heart, this is aorta, and aorta branches into many arteries, and arteries branches into many arterioles, and arterioles ultimately branches into tiny vessels called capillaries, and capillaries, many capillaries join to form venules, and many venules join to form veins, and veins ultimately drain into superior vena cava and inferior vena cava, and superior vena cava and inferior vena cava ultimately drains into the heart. In this total cardiovascular system, we will concentrate only on the arteriole, not any other part, only on the arteriole. If you do a cross section of the arteriole, you will find three layers. This black layer is called tunica intima, this middle red layer is called tunica media, and outer green layer is called tunica adventitia. Of the arteriole, tunica intima is composed of single layer of endothelial cell. This is endothelial cell. Tunica media is composed of smooth muscle cell. These red cells are smooth muscle cells, and tunica adventitia is composed of connective tissue. We will concentrate our discussion on the smooth muscle cell of the tunica media of the arteriole. you all know that blood pressure equal to cardiac output into total peripheral resistance. That means if your cardiac output goes up, your blood pressure goes up, or if your total peripheral resistance goes up, your blood pressure goes up. Total peripheral resistance mainly depends on the diameter of the arteriole. So if the arteriolar diameter is more, your total peripheral resistance is less, or if your arteriolar diameter is less, your total peripheral resistance is more. Again, the diameter of the arteriole depends on the tone of the smooth muscle in the tunica media of the arteriole. It means this smooth muscle in the tunica media of the arteriole actually determines the tone of the arteriole, and tone of the arteriole actually determines the diameter of the arteriole. If this smooth muscle in the tunica media of the arteriole contracts, diameter of the arteriole become less, and when diameter of the arteriole become less, your total peripheral resistance goes up, and when your total peripheral resistance goes up, your blood pressure goes up, because blood pressure equal to cardiac output into total peripheral resistance. On the other hand, if this smooth muscle in the tunica media of the arteriole relax, your arteriolar diameter becomes more, and if your arteriolar diameter becomes more, then your total peripheral resistance goes down. When your total peripheral resistance goes down, your blood pressure falls. So when this arteriolar smooth muscle in the tunica media relaxes, your artery dilates, and when your artery dilates, your total peripheral resistance goes down and your blood pressure goes down. Now we will discuss about the mechanism of contraction of vascular smooth muscle, or mechanism of contraction of smooth muscle of the arteriole. But before understanding the mechanism of contraction of smooth muscle of the arteriole, first we have to understand some important features of the smooth muscle of the arteriole. So suppose this red box represents smooth muscle of the arteriole, and this red line represents the cell membrane of the smooth muscle of the arteriole, and on the cell membrane you can see this is a voltage sensitive L type of calcium channel. So on the cell membrane of smooth muscle we have very important, this channel called voltage sensitive L type of calcium channel. This is the extracellular fluid and this is the cytoplasm. You can see in the extracellular fluid there are lots of calcium, free calcium ion in the extracellular fluid, and this is the cytosol, and this is the sarcoplasmic reticulum. Endoplasmic reticulum in the smooth muscle is called sarcoplasmic reticulum, and inside the sarcoplasmic reticulum lots of calcium ion is stored, and this is the membrane of the sarcoplasmic reticulum. On the membrane of sarcoplasmic reticulum we have two things. This is a protein called Raynaudine receptor. This green protein is called Raynaudine receptor. This Raynaudine receptor is located on the membrane of sarcoplasmic reticulum, and this is a calcium channel located on the membrane of sarcoplasmic reticulum. This calcium channel in unstimulated smooth muscle is closed. You can see this calcium channel is closed, and this is the cytoplasm. In the cytoplasm you can see there is no calcium. So in the cytoplasm we can say that calcium concentration is almost zero or tends to zero. In the cytoplasm we have three other important protein. One protein, this black protein, is calmodulin. There is another important protein called myosin light chain. You can see this is a green protein called myosin light chain, and there is another important enzyme located in the cytoplasm of smooth muscle. This enzyme is called myosin light chain kinase. If you understand all these basic features of vascular smooth muscle, now we can proceed how vascular smooth muscle contracts. When vascular smooth muscle is stimulated, suppose vascular smooth muscle is stimulated, there is opening of voltage sensitive L type of calcium channel. So first event is opening of the voltage sensitive L type of calcium channel. When voltage sensitive L type of calcium channel opens, as extracellular fluid calcium concentration is more than the cytoplasm, so calcium flows from extracellular fluid into the cytosol. because there is concentration gradient. Then this cytosolic calcium that enters from the extracellular fluid binds with ryanodine receptor on the sarcoplasmic reticulum. When calcium binds with ryanodine receptor on the sarcoplasmic reticulum, this calcium channel located in the membrane of sarcoplasmic reticulum opens automatically. When this calcium channel in the membrane of sarcoplasmic reticulum opens, calcium flows from the matrix of sarcoplasmic reticulum into the cytosol. So this is the matrix of sarcoplasmic reticulum. When calcium channel on the membrane of sarcoplasmic reticulum become opened, calcium moves from matrix of sarcoplasmic reticulum into the cytoplasm. This is called calcium induced calcium release, because extracellular fluid calcium stimulates the release of calcium from the sarcoplasmic reticulum. So calcium stimulates the release of calcium. This event is called calcium induced calcium release. Due to this calcium induced calcium release, cytosolic calcium concentration goes very high. So there are lots of calcium ion accumulate in the cytoplasm of vascular smooth muscle. Then this calcium ion form complex with calmodulin and forms calcium calmodulin complex. This calcium calmodulin complex activates a protein called myosin light chain kinase. You can see calcium calmodulin complex activates myosin light chain kinase. When myosin light chain kinase, what is the function of a kinase? The function of a kinase is to phosphorylate its target protein. So what is the target of myosin light chain kinase? It is very understandable that the target of myosin light chain kinase is myosin light chain. Myosin has both heavy chains and light chains, and myosin light chain kinase only phosphorylate the light chain of myosin. So this is a myosin light chain, and this myosin light chain become phosphorylated. You can see the red phosphate group is added on the myosin light chain. When phosphate group is added on the myosin light chain, it can interact more with actin. So there is more actin and myosin interaction, and more actin and myosin interaction lead to contraction of vascular smooth muscle. So more actin and myosin interaction leads to contraction of vascular smooth muscle. When your vascular smooth muscle contracts, your arteriole becomes narrow. So when your arteriolar smooth muscle contracts, your arteriole become narrow, and when your arteriole become narrow, diameter of the arteriole goes down. So when diameter of the arteriole goes down, your total peripheral resistance goes up, and when your total peripheral resistance goes up, your blood pressure goes up. So we can see again review that extracellular fluid calcium enters inside the smooth muscle of arteriole through voltage sensitive air type of calcium channel. Calcium that enters from ECF stimulates the release of more calcium from sarcoplasmic reticulum. This is called calcium induced calcium release. So as a result of this calcium induced calcium release, cytosolic or intracellular calcium concentration gets high, and these intracellular calcium or cytoplasmic calcium form complex with calmodulin, and this calcium calmodulin complex activates myosin light chain kinase, and this activated myosin light chain kinase phosphorylate myosin light chain, and when their myosin light chain is phosphorylated, there is increased actin and myosin interaction. Increased actin and myosin interaction lead to contraction of arteriolar smooth muscle, and when arteriolar smooth muscle contracts, your arteriole become narrow, and when your arteriole become narrow, your diameter of the arteriole is less, and when diameter of the arteriole become less, total peripheral resistance goes up, because total peripheral resistance is determined by the diameter or radius of the arteriole. When radius of the arteriole goes down, total peripheral resistance goes up, and when total peripheral resistance goes up, your blood pressure goes up, because mean arterial pressure equal to cardiac output into total peripheral resistance. So we can summarize that due to activity of voltage sensitive air type of calcium channel, there is contraction of the arteriole, and due to contraction of the arteriole, your total peripheral resistance goes up and your blood pressure goes up. So how does amlodipine, nifedipine, larcanidipine and clinidipine lowers the blood pressure? If you administer amlodipine or nifedipine or larcanidipine or clinidipine to a patient, These drugs blocks voltage sensitive air type of calcium channel on the arteriolar smooth muscle. When these drugs blocks voltage sensitive air type of calcium channel on the arteriolar smooth muscle, there will be less calcium entry into the cytoplasm of the smooth muscle. When there is less calcium entry, there is no release of calcium from the sarcoplasmic reticulum. So there is no calcium induced calcium release. Because this extracellular fluid calcium stimulates the release of calcium from the sarcoplasmic reticulum. When extracellular fluid calcium cannot enter into the smooth muscle, calcium is not released from the sarcoplasmic reticulum. So your intracellular calcium concentration goes down. So when your intracellular calcium concentration goes down, calcium calmodulin activity of formation of calcium calmodulin complex goes down. So the activity of calcium calmodulin complex goes down. When the activity of calcium calmodulin complex goes down, there is decreased activation of myosin light chain kinase. When myosin light chain kinase is less active, there is less phosphorylation of myosin light chain. When there is decreased phosphorylation of myosin light chain, or myosin light chain is less number of myosin light chain is phosphorylated, there is decreased interaction with actin. So actin myosin interaction goes down. When actin myosin interaction goes down, these events leads to relaxation of the smooth muscle of the arteriole. So arteriolar smooth muscle relax. When arteriolar smooth muscle relax, arterioles become dilated, and when your arteriole become dilated, your diameter of the arteriole goes up, or radius of the arteriole goes up. When your arteriolar radius or diameter goes up, your total peripheral resistance falls, and when your total peripheral resistance falls, your blood pressure goes down. This is the mechanism how amlodipine or nifedipine lowers your blood pressure. Second important indication of dihydropyridine group of calcium channel blocker is Raynaud's phenomenon. So what happens in Raynaud's phenomenon, when in a very sensitive person is exposed to cold, or person is in emotional stress, there is excessive constriction of smooth muscle of arterioles of fingers and toes. That means the blood vessel that supplies the fingers and toes constrict excessively. When blood vessel supplies the fingers and toes constrict excessively, there is decreased blood supply to the capillary, or there is decreased blood supply to the fingers and toes. When blood supply to the fingers and toes is decreased, there is ischemia of the fingers and toes, and ischemia of the fingers and toes leads to pain, numbness or paresthesia in the affected fingers and toes. So in Raynaud's phenomenon, in cold or emotional stress, there is excessive vasoconstriction or arteriolar constriction or constriction of smooth muscle of arteriole that leads to ischemia of the fingers and toes, and ischemia of the fingers and toes leads to pain, and even in serious cases necrosis, numbness, paresthesia of the affected fingers and toes. So what calcium channel blocker do? Calcium channel blocker blocks air type of calcium channel on the smooth muscle of arterioles of fingers and toes. When calcium channel blocker blocks calcium channel on the smooth muscle of arterioles of fingers and toes, smooth muscle of the arteriole relaxes. When smooth muscle of the arteriole relax, diameter of the arteriole becomes more, so there is increased blood supply to the fingers and toes. So there is prevention of digital ischemia. So calcium channel blocker basically dilates or prevents these vascular spasm and increase by blocking calcium channel on the vascular smooth muscle and increase blood supply to the fingers and toes. Second, in some disease process, like if you have SLE, systemic lupus erythematosus, or if you have systemic sclerosis or scleroderma, in this disease there is inflammation of the wall of the blood vessel, particularly of the fingers and toes. If there is inflammation of the wall of the blood vessel of the fingers and toes, these inflamed blood vessel constrict excessively upon stimulation by sympathetic nervous system. So when these inflamed blood vessel are stimulated by sympathetic nervous system, they constrict excessively. So there is excessive narrowing of the blood vessels of the fingers and toes in SLE and scleroderma. When there is excessive constriction and narrowing of the arterioles of the fingers and toes, there is less blood supply to the fingers and toes, so there is digital ischemia, and due to this digital ischemia there is pain, numbness and necrosis. So in SLE and scleroderma, independent of the blood pressure of the patient, you can use nifedipine or amlodipine to relax the smooth muscle of the arteriole, and by relaxing the smooth muscle of the arteriole you can improve blood flow to the fingers and toes. Third use is preterm labor. So what happens in labor? In labor, first there is regular uterine contraction. When uterus contracts, then your cervix dilated, and when cervix is dilated, baby is expelled from the uterus through the birth canal. So baby is expelled from the uterus through the birth canal, or we can tell that the baby is born. But if this uterine contraction, regular uterine contraction or labor, starts before 36 weeks, we call it preterm labor. So what are the problems in preterm labor? Problems of preterm labor is that there are many problems of preterm baby. First, the baby is underweight. Second, preterm baby doesn't have enough surfactant in his or her lungs, so there is breathing difficulties or shortness of breath. Second, preterm baby has underdeveloped organs, and preterm baby has problems in vision. We call it retinopathy of prematurity. Or there is also necrotizing enterocolitis. So there is many problems of a preterm baby. So we never want that a baby is or should born before 36 weeks. So what we can do? Suppose a lady come to you and her uterus is contracting at 28 weeks. So what you can do? Now we can see how uterine smooth muscle contracts. So uterus has three layers, you know. This is endometrium, this red layer is myometrium, and outside black layer is called perimetrium. In the myometrium we have uterine smooth muscle. This uterine smooth muscle have calcium channel on its surface. When this calcium channel is stimulated, calcium enters from extracellular fluid inside the cell, and when calcium enters from ECF into the cytosol of uterine smooth muscle, this calcium formed complex with calmodulin, and this calcium calmodulin complex causes contraction of uterine smooth muscle. So entry of calcium through voltage sensitive L type of calcium channel initiate uterine smooth muscle contraction, and uterine smooth muscle contraction leads to labor. So what you can do? You can give a calcium channel blocker. Calcium channel blocker blocks this voltage sensitive L type of calcium channel. So calcium cannot enter from ECF inside the uterine smooth muscle and cannot initiate uterine contraction, and this leads to relaxation of, when calcium cannot enter from ECF into the uterine smooth muscle, there is relaxation of the uterine smooth muscle, and relaxation of the uterine smooth muscle, when uterine smooth muscle relaxes, there is prevention of preterm labor. So we can use calcium channel blocker like nifedipine in preterm labor. Our fourth indication is fringe metal angina. Angina is of three types: unstable angina, stable angina, and fringe metal angina. Fringe metal angina is also called vasospastic angina. It is also known as variant angina. So what happens in fringe metal angina? This is heart. This blue line represents endocardium, green portion represents the myocardium, and black portion represents the pericardium. On the pericardium, you know that coronary artery is located on the pericardium. What happens in fringe metal angina? This coronary artery undergo spontaneous vasospasm. There is episodic spontaneous vasospasm of the coronary artery. When this coronary artery undergo vasospasm or vasoconstriction, there is myocardial blood supply become less. So myocardium become ischemic or hypoxic. In ischemic and hypoxic condition, there is anaerobic glycolysis occur in the myocardium, and when there is anaerobic glycolysis occur in the myocardium, there is production of lactic acid and there is utilization of adenosine triphosphate and production of adenosine diphosphate. This lactic acid and adenosine diphosphate stimulate pain receptor and causes chest pain or discomfort in variant angina. So what happens in variant angina? There is spontaneous episodic spasm of coronary artery. This spasm leads to decreased myocardial blood flow. Decreased myocardial blood flow leads to myocardial ischemia and myocardial hypoxia. That it means there is decreased supply of oxygen and nutrition to the myocardium. When oxygen and nutrition supply to the myocardium is decreased, there is anaerobic process occurs in the myocardium, and during anaerobic metabolism there is production of lactic acid and adenosine diphosphate. This lactic acid and adenosine diphosphate stimulate pain receptor in the myocardium. Myocardium is supplied by cervical 7 to thoracic 4 dermatom. So there is basically when pain fiber around the myocardium is stimulated, there is substernal chest pain, discomfort or pressure like sensation or heaviness, and this pain can radiate anywhere from cervical 7 up to thoracic 4 dermatom. So this pain can be felt anywhere in the inner aspect of arm, in the lower jaw, in the neck, in the upper epigastrium or in the shoulder, radiate anywhere. So this spontaneous episodic vasospasm of coronary artery is responsible for variant or vasospastic or fringe metal angina. Calcium channel blocker relieves the vasospasm of coronary artery by blocking a type of calcium channel on the smooth muscle of the coronary artery. So calcium channel blocker blocks a type of calcium channel on the smooth muscle of coronary artery. So there is prevention of spasm of coronary artery. When coronary artery spasm is prevented, there is dilatation of coronary artery, and when there is dilatation of coronary artery, there is prevention of myocardial ischemia, and when myocardial ischemia is prevented, you have relief of symptoms of variant angina. So by dilating the spastic coronary artery, by blocking their type of calcium channel and dilating the spastic coronary artery, this spastic coronary artery, dilating this spastic coronary artery, calcium channel blocker improves blood supply to the myocardium and relieves ischemia of the myocardium. Thus, it is useful in fringe metal or vasospastic angina. Then two special indication of a important and special calcium channel blocker called Nimodipine. Nimodipine is used in two conditions. One is subarachnoid hemorrhage. Another indication is intracerebral hematoma with ventricular extension. So what happens in subarachnoid hemorrhage? So suppose this is a brain tissue. This black box represents brain tissue. This blue box represents subarachnoid space, and in the subarachnoid space you know that there is cerebrospinal fluid, and through this subarachnoid space cerebral artery runs. So cerebral artery runs through this subarachnoid space. What happens if there is blood in the subarachnoid space? So this is again the brain tissue, and this is again the subarachnoid space, and this is CSF, and this is cerebral artery. When there is blood in the subarachnoid space, this blood, oxyhemoglobin of this blood irritates the smooth muscle of cerebral artery. When smooth muscle of the cerebral artery is irritated, they undergo spasm. So there is constriction of the smooth muscle of cerebral artery. When smooth muscle of the cerebral artery is constricted, blood supply to the brain tissue is decreased. There is decreased blood supply to the brain tissue, and this leads to cerebral ischemia, and cerebral ischemia is very, very dangerous for the patient. So we can tell that in subarachnoid hemorrhage there is blood in the subarachnoid space. This blood in the subarachnoid space irritates smooth muscle of cerebral artery, and this, when cerebral artery smooth muscle is irritated, there is contraction of smooth muscle of cerebral artery, and contraction of the smooth muscle of cerebral artery leads to narrowing of cerebral artery. When cerebral artery is narrowed, there is decreased blood supply to the brain tissue, and when there is decreased blood supply to the brain tissue, brain suffers from ischemia, and this is very dangerous. So what we can do? We can give Nimodipine. When we give Nimodipine, Nimodipine is highly lipid soluble. they goes to the brain and they selectively dilates this cerebral artery. So this cerebral, they blocks a type of calcium channel on the smooth muscle of this cerebral artery, and they selectively dilates the cerebral artery. When the cerebral artery is selectively dilated, this improves blood supply to the brain tissue. So in subarachnoid hemorrhage, we can use Nimodipine. For those who are interested, or in clinical books it is written that this cerebral artery spasm starts on day 4 of subarachnoid hemorrhage. They peak at day 7 and they persist up to day 21. So in the ward, if you get a patient of subarachnoid hemorrhage, you prescribe him or her Nimodipine up to 21 days of subarachnoid hemorrhage. We practice in the ward, we practice this in the ward a lot. So what does the Nimodipine do? The Nimodipine basically selectively blocks calcium channel on cerebral blood vessel. This leads to dilatation of cerebral blood vessel. So spasm of cerebral artery is prevented. When spasm of cerebral artery is prevented, there is prevention of cerebral ischemia. Second indication is intracerebral hemorrhage with ventricular extension. So if this is the brain tissue, this blue box represents ventricle of the brain, and there is rupture of a blood vessel. Suppose a blood vessel is ruptured in the brain parenchyma and there is intracerebral hematoma. If this intracerebral hemorrhage extended into the ventricular system, this condition is called intracerebral hemorrhage with ventricular extension, and I swear that you will find this condition a lot in your clinical practice in emergency. So when this intracerebral hematoma extends into the ventricle, we can call that blood in the brain parenchyma extend into the ventricle. In the ventricle, you know, there is CSF. So blood, when the blood from the brain parenchyma extend into the ventricle, we can tell that blood extends into the CSF of the ventricle, and through this CSF of the ventricle, this CSF has this ventricular CSF. You know, this ventricular CSF has connection with CSF of subarachnoid space. So when blood comes into the CSF of the ventricle, through this CSF or cerebrospinal fluid, this blood goes into the subarachnoid space. And when blood is in the subarachnoid space, same thing happened like subarachnoid hemorrhage. They irritate the cerebral artery, and when they irritate the cerebral artery, there is spasm. There is spasm of cerebral artery. When there is spasm of cerebral artery, healthy brain tissue, suppose this is a healthy brain tissue, this is a healthy brain tissue, this is a healthy brain tissue. Apart from hematoma, this healthy brain tissue suffers from ischemia because there is spasm of cerebral artery. This blood through ventricular CSF goes into CSF of subarachnoid space, and they irritate the cerebral artery in the subarachnoid space and causes spasm of cerebral artery in the subarachnoid space. So this healthy brain tissue suffers from ischemia, and this is very dangerous for the patient. So we will give Nimodipine. Nimodipine blocks calcium channel on the cerebral artery and they selectively dilates this cerebral artery. When Nimodipine is given, this vasospasm is prevented. So your brain, healthy brain tissue, healthy brain tissue that suffers from ischemia due to this vasospasm, this event is prevented by Nimodipine. Last but not the least, there are some side effects of dihydropyridine calcium channel blocker. First important side effect is edema, or most importantly ankle edema. You will find this a lot in clinical situation. Don't panic, this is very common and this is a benign condition. It is not dangerous for the patient. Second important adverse effect is hypotension, because calcium channel blocker lowers your blood pressure. So if you dose excessively, this can lead to hypotension. Third important, or lightheadedness. Third important thing, any vasodilator can cause reflex tachycardia and palpitations. Fourth important adverse effect is flushing, and any vasodilator can lead to headache. I will just explain one adverse effect of calcium channel blocker, that is reflex tachycardia. Suppose this is heart, this is aorta, and this is artery, and this is arteriole, and this is capillary. This is SA node, this is AV node, this is central nervous system, and this is spinal cord. This is the preganglionic neuron, and this is the postganglionic neuron. When you give calcium channel blocker, your arteriole dilates, and when your arteriole dilates, your blood pressure falls. When your blood pressure falls, this fall in blood pressure is sensed by baroreceptor. This is the baroreceptor. This baroreceptor is located in the arch of the aorta and in the bifurcation of the common carotid artery. So when this baroreceptor sense that there is less blood pressure, they through vagus and glossopharyngeal nerve. This baroreceptor sends signal to the brain or medulla oblongata of the brain. This baroreceptor tells the medulla that blood pressure in the body is falling. So what the medulla do? Medulla, from the central nervous system, there is outflow occurs, and this outflow first come into the spinal cord, and through the spinal cord this outflow goes into the heart. And when goes into the heart, it means when blood pressure falls, this baroreceptor sense that there is low blood pressure, and this baroreceptor is innervated by cranial nerve 9 and 10, so that send information to the brain that blood pressure is falling, and from the brain there is increased sympathetic outflow to the heart and blood vessel. When there is increased sympathetic outflow to the heart, there is preganglionic neuron of the sympathetic nervous system and postganglionic neuron. Postganglionic neuron release non-epinephrine, and this non-epinephrine stimulate beta 1 receptor of the SA node. When beta 1 receptor of the SA node is stimulated, there is increased firing rate of SA node. That means discharge or firing rate of SA node goes up. When firing rate of SA node goes up, your heart rate goes up, or we call it tachycardia or palpitations. Palpitations is patient tell that they have palpitation. So as there is tachycardia occurs due to calcium channel blocker by giving calcium channel blocker, and this tachycardia is mediated by this baroreceptor reflex, so we call it reflex tachycardia. And when calcium channel blocker dilates the arteriole, there is increased blood come into the capillary. When increased blood come into the capillary, there is increased redness of the skin. This can lead to flashing, and when there is vasodilatation, this can lead to headache. But the most common adverse effect is ankle edema. In amlodipine, there is very less likely that reflex tachycardia will occur. Reflex tachycardia is more common in felodipine and nifedipine. So we will only discuss about dihydropyridine, but we doesn't discuss about diltiazem or verapamil. In later lecture, we will discuss about diltiazem and verapamil. Thank you everyone. Thank you.